This conference will now be recorded.
Okay, thank you. Hello, good morning, all. Just there is a bit of technical. Yeah, the audio was not functioning before, so so the delay actually. So sorry for that. Please do join 34 and yeah, we'll start the session in 2 minutes. Yeah, am I audible to you?
Yes, sir.
Am I audible? Yeah. Okay. Thank you. Thank you. Thank you. Yeah, I think we'll start 85. Please do join. And yeah, once again, sorry for the technical delay. Today's is probably the last theory topic of pediatrics as of I know actually. Yeah, your syllabus for pediatrics has been already being dealt, it seems. And yeah. Yeah, today we'll discuss about two topics, just in brief, for exam purpose, and this is good for your medicine and pediatrics. And yeah, so let us start. Yeah, there can be a CNS case for undergrad. Yeah, don't know, but yeah, Guillain Barre syndrome and Duchenne muscular dystrophy. Okay. Two topics, both one is neurology and the next is musculoskeletal disorder. Okay, yeah, let us jump in. We'll start with Guillain Barre. Okay, you must be knowing the name is derived from the scientists, the physicians who are working on this syndrome. Guillain Barre syndrome is an acute, everything is important, acute inflammatory polyneuropathy characterized by rapidly progressive, essentially symmetrical weakness and areflexia in a previously well child. So every word is important and that specifies the nature of the disease, the whole definition. It is an acute, it is happening in less time, an inflammatory polyneuropathy. Where is the anatomical diagnosis is the neuropathy. Some books says that it is polyradiculopathy, or polyneuropathy, whatever. But neuropathy is a blanket term which involves everything: the roots of the nerve, the radicals of the nerve, and the nerve itself. Okay, it is polyneuropathy. You can as well say that radiculopathy also. It is an inflammatory one, which is characterized by, now coming to the clinical features, it is a rapidly progressive, yeah, in its action it is very progressive, and essentially symmetric weakness. It is symmetrical weakness. It is not like unilateral, just like we see in poliomyelitis or other disorders like a traumatic neuritis. It is not unilateral. It is a symmetrical, bilateral, equally affecting. And areflexia, by nature, it is weakness. So what is weakness is the loss of power is weakness. Once the power is lost, we don't expect, the muscles goes flaccid and the reflexes goes blunt. Okay, so this three lines explains the disorder, and if a theory question comes, you just explain these three lines, that is done for the day. Actually, you can get out of it. Okay, now coming to the weakness, it is usually distal. Just remember, all the neurological disorders are distal weakness. All the muscle disorders are proximal weakness. There are few exceptions, but exceptions are for entrance exam. SMA, being a neurological disorder, will have a proximal weakness of the muscles, and um, and myodystrophies, myotonic myodystrophies are muscle disorder which will have distal impact. Okay, just remember, as a rule, neurology, the distals are gone, and muscle, the proximals are gone. Okay, just remember this. This is a universal thing. Here, the weakness, the being a neurological disorder, here the weakness is usually distal, and there is a neuropathic pain which is prominent in many of the affected children. There is element of pain which is not there in the definition, but being an inflammatory condition, we can expect pain. Pain do occur in these children, and the pain is usually over the back, headache, neck pain, and over the back. They will say that there is a pain because the radicals are being inflamed and affected. So there is a dull aching pain. They cannot localize it because it is very diffuse over the spinal cord, and it is not specified to the point. Okay, so pain is also a factor there. Okay, GBS is the most common cause of acute flaccid paralysis in childhood. Previously, a few decades ago, it used to be poliomyelitis, because of the advent of immunization programs and national schemes, and the general awareness of the people regarding the vaccination thing. Uh, we are seeing polio rare and rare, and it is eliminated. So now the second thing has come up. This is Guillain-Barré syndrome, which is now the most common cause of acute flaccid paralysis. And the variable incidence of Guillain-Barré is in different populations may reflect differential genetic susceptibility or exposure to causative pathogens. See, whenever they're finding GBS in a few localities, they're finding it more recurring or more happening. So they found that maybe there is a genetical susceptibility to this population or this area, and any other exposures, causative exposure, like maybe there is something else that is predisposing a child to go into GBS. Okay, now coming to the clinical features, how does a child, when do you suspect GBS in a child? Is Guillain-Barré develops 2 to 4 weeks after a prodromal gastroenteritis or respiratory illness. Just remember, this is just like our glomerulonephritis. Go back to the history and ask for any respiratory illness. The same thing happens. Go back to the history and ask for any respiratory illness or gastroenteritis. And now the child is presenting with absolute weakness and fatigue and paresthesia and pain. As we discussed, it is a radiculopathy, all the radicals, and it is having a dull aching pain over the back, headache, and neck, and have difficulty in walking because of the weakness. The child who is actively playing, running, jumping, everyone, whatever is happening, now the child sits, doesn't move much, and pain in the back and the legs, and doesn't walk or initiate any movement. Okay, these are the things which constitute a child of GBS, and it is difficult from arising from the floor and climbing stairs. This is a late manifestation rather. First of all, the child doesn't want to move. A well-active child doesn't want to move, sits wherever he is, or sleeps on the couch whenever possible. Now, this is the initial presentation, and over days, it is an acute condition. Within days, the child will go into absolute flaccidity and doesn't move at all, and he can experience the paresis of the both lower limbs. What happens is, this is the classical presentation. It happens at the distal, the lower limbs mostly symmetrically involved. There'll be pain, there'll be weakness, difficult to walk, difficult to move, and just moving around. Okay, and the same thing, you ask the history of any respiratory illness or GI illness within 2 to 3 weeks into the past. Okay, and weakness is generally symmetrical. As we discussed, it is symmetrical, remember, because it is a radiculopathy. It is at the spinal cord, it is at the center, so it can distribute in both ways. It is not at the nerve region involving in the nerve, so it is not happening in the unilateral or any specific area, or it is not focal. It is usually, you can imagine it as a symmetrical presentation, and starting in the lower extremities, then ascending into the upper extremities over days to weeks. Okay, as we discussed, it is the difficulty of walking the lower limbs, and slowly ascends upwards, and upper limbs gets involved. Then, in a more serious manifestation, the respiratory muscles, the diaphragm, and the intercostal and external and internal coastal muscles gets involved, and those will result in respiratory paralysis. Okay, this pain is often poorly localized, and recognition of this symptom is especially important in young children, in whom irritability and refusal to weight bear is the initial presentation. As we discussed, children, because they may not say that he's unable to walk, he's not moving or something. So a 3-year-old or 4-year-old, he'll be irritable because he knows that he is unable to. He used to walk, he can run, but suddenly he finds that it is very difficult to pull his own legs to make a movement. So the child goes unrest. He'll be irritable. He'll be very weird behaving actually. So that is how even we should think of when the child is not moving around much, not using his limbs, then that is when we need to think that maybe something is wrong with the limbs. Okay, and initially there can be ataxia, because if not, it is not the complete weakness. Slowly the weakness develops. So a well walking and well balanced child will start wobbling around, and he doesn't walk in a straight line or in a right pace. Okay, so there may be ataxia. That is logical, right? When someone is losing power over the limbs, so he's bound to be in a disarray. And then sensory loss is very common in children with GBS. Okay, usually sensory loss maybe a manifestation, because the manifestation of GBS can be motor, sensory, and autonomic, and can be all three, or in a different combination, like motor and sensory, and motor and autonomic dysautonomia, like that. Okay, a motor, sensory, and autonomic, and they can have different manifestation because it affects the main radicals. Okay, the no at the root. Okay, then there is one. There are multiple variants. We'll discuss in the subsequent. And one thing is of importance. So Miller-Fisher syndrome. It is a triad of ataxia. As we discussed, there will be imbalance in walking, like a drunken gait, right? Wide-based legs, a little bit drunken gait, ataxia. He wants to keep up with his balance. Okay, that is how ataxic gait is. And then ophthalmoplegia and areflexia without peripheral weakness. You know, these three, because GBS, having said that, all the things which we have told, bilateral, symmetrical, weakness, pain, areflexia, all these, they're exception to all these things. Okay, So they found that there are variants of GBS, not the classic GBS, which has been identified and initially documented by the Guillain Barre himself. Okay, Guillain and Barre, the two scientists. Okay, so as the time goes, there are a lot of variations that have been presented. Like one of it is your Miller fishes, where ataxia, ophthalmoplegia, and areflexia. You remember this? This is an entrance stuff. Okay. Yeah, coming to the respiratory muscle weakness, why GBS is not that the child is unable to walk, not that the child is having trouble in walking. It is because it is ascending and it can goes to the respiratory muscles. It can affect the diaphragm. It can affect the respiration. That is our concern. Okay, respiratory muscle weakness in GBS is usually slowly progressive and tends to correlate with the degree of limb weaknesses. And the number of atypical presentation of pediatric GBS are present, as we discussed. It is not just the paraplegia, like not just the lower limbs alone. Paraplegia is the involvement of lower limbs alone. Okay, not that. It can present with quadriplegia. All four limbs can be affected, and all the limbs may have areflexia, and there may be respiratory failure. Exactly, respiratory failure. It may not follow a pattern of down to above. Excuse me. Yeah. And respiratory failure, they may directly go into the respiratory failure, and effectively people can be locked in with all these things. There is quadriplegia, areflexia, and respiratory failure locked in. He now cannot be excitable. The peripheral nerve will not be excitable, and he will be just lying down. He can perceive everything, but he cannot move a thing. Okay, that is a locked in condition. Okay, uh, if that is there, the prognosis is bad. Okay, locked in is quadriplegia, areflexia, and respiratory failure. He can perceive anything. The neurophysiological studies will show that the peripheral nerves are not excitable. They cannot be stimulated and nothing pass through the peripheral nerve. Okay, now coming to the physical examination. So this is the history how the child comes, and now you are going to examine the child. What is happening? There is be weakness. Yes, loss of power is there, and there is loss of muscle stretch reflexes. These deep tendon reflexes are being gone. Areflexia. Weakness usually begins in the legs and progresses rostrally, but can be proximally predominant at onset. Okay, so the weakness is yeah, as we discussed, it is ascending type of paralysis. It happens at the legs and slowly ascends up into the upper limbs and the trunk and the respiratory muscles subsequently. Okay, this is the rostral progression. Rostral is to the head, caudal and rostral, all the stuff. Okay, and reflexes are usually lost in the first week of the illness, but are occasionally preserved. As we told, but whenever you are giving an exam or some examiner asks you, always tell the classical manifestations. Okay, don't tell that. Yes, reflexes can be present in few in GBS. So GBS is not known for that. GBS is known for areflexia. GBS is known for symmetrical weakness. GBS is known for the polyradiculopathies. Okay, all these variations, yes, they do occur, but yeah, these are all exceptions. Don't answer this as the first thing. Okay, answer the classic things first, and if examiner wants to know more about GBS from you, so then slowly tell that yes, in sometimes few cases reflexes may be perceived preserved, and you can get a reflex. And hyperreflexia and GBS usually in patients with acute motor axonal variant can be present. These are all entrance bits, so just I have made it up, but for theory I don't want to confuse you. Yes, there can be hyperreflexia also. GBS is known for areflexia, but hyperreflexia also can be there. Your tendon reflexes may be brisk and exaggerated in few conditions, like when a motor axon is involved, that can give an hyperreflexia. Okay, this is an entrance thing, so I have put. Otherwise, GBS is areflexia. You remember that whenever you're answering an examiner, it is that. Okay, but in your entrance, remember that acute motor axonal variant can have hyperreflexia. Yeah, as we discussed, it is not the motor, it is not the sensory. Even autonomic gets involved with blood pressure instability, sinus tachys, and pupillary abnormalities like constriction and dilatation of pupil, and abnormal pupillary reaction, and abnormal sweating. All the autonomic stuff that is happening. Okay, blood pressure inability, not to there'll be variation of the blood pressure, not maintaining it properly, and tachycardia, heart rate is gone. and pupil sizes are flickering now and then, and abnormal sweating can be present even in a cold atmosphere. The child starts sweating. Okay, all these things are being affected. Okay, you know that what is motor affection is loss of power, sensory affection is loss of sensation, but usually in pediatrics sensations do preserve. Okay, and areflexia. Okay, and autonomic manifestation is that. Even this is the same thing in adult population, but the only difference is adult population is mostly motor. Okay, mostly motor. And the clinical variants of Guillain-Barre, this is something of interest. The subtypes are being classified based on the involvement of peripheral nerve, motor, and sensory axons. How much of motor axons are involved? How much of sensory axons are involved? By this, they have differentiated, not the classic GBS that has been described. There may be variations, there may be a spectrum. There is a lot of gray area. It is not just white and black. There is a lot of gray area in between because of differential involvement of the motor and sensory axons. Yeah, most common type is your acute inflammatory demyelinating polyneuropathy. AIDP is most common. It is the classic, and 95% of the cases in Western nation and Indian studies are not very much into GBS. Even in Indian population, it is AIDP. If AIDP, acute inflammatory demyelinating polyneuropathy, it is GBS in our condition. Okay, that is inflammatory process is the most commonly occurring. The pathological basis is acute injury mediated by activated T cells and antibody responses to Schwann cells and myelin epitomes in spinal roots and peripheral nerves. See, this is important because this constitutes your labs, this constitutes your management, because what happens is an acute injury to the nervous system, where what are the cells that get me? Schwann cells and myelin epitomes in the spinal roots and peripheral nerves, and not just the roots of the spinal cord, it is also the peripheral nerves. And how it is happening? It is because of the immune reaction by activated T cells and antibody responses. Okay, this is how an inflammatory injury is happening to the nervous system in case of GBS. So everything has its implication, because you are going to do an anti-inflammatory medication because you know that it is happening, and you are going to suppress the immunity because you know that it is an immune reaction. Okay, that is why your pathology is important. And in another condition, most common, the next common is acute motor axonal neuropathy, which we have now known for having hyperreflexia. It is commonly called AMAN, AMAN. A form of GBS mimics the inflammatory demyelinating polyneuropathy, but its fulminant motor deficits are not associated with sensory deficits. As the name suggests, it is only the motor axonal neuropathy. So the motor got involved, the sensory is very much intact. Okay, this is the next most common type happening. This is 75%. It is acute inflammatory demyelinating polyneuropathy, and then rest is your motor. How you can identify this is by electrophysiological studies. You do a nerve conduction study, you do nerve physiological studies, then you find out. This is a lot of technical aspects. This is flattening of the F waves, and those gives that the axons are not being excited properly, and they have been flattened up. So that is how you identify that there is demyelination in the tract. Okay, that is a new nerve physiological studies. Okay, that is not for this, not for today actually. Yeah, okay. And yeah, another thing is your Miller-Fisher syndrome. Yeah, this is again entrance. It is, I'm repeating it again, ophthalmoparesis, ataxia, and areflexia can also be associated with bulbar weakness, and such children often have a clinical picture that later involves the truncal and limb weakness. Okay, first it usually we expect that GBS to happen from the legs and above, but in Miller-Fisher, what happens is your ophthalmoplegia. I think you must be knowing your Miller-Gubler's syndrome of third nerve involvement in the sixth nerve, this ophthalmoplegias in your opthal subject. That is something like Miller-Fisher thing, and ataxia and areflexia will be present, and there will be bulbar weakness. There will be difficult swallowing. There will be pooling of secretions. They can aspiration of the secretions because of bulbar weakness, and then they'll get into the limbs. Okay, this is a variant. Okay, the classic is ascending. This is a variant. This can happen in a haphazard way. Okay, coming to the pathophysiology, as we already discussed, it is likely an autoimmune disorder resulting from B cells and T cell activation and production of antibodies directed to the antigenic proteins of the peripheral nerves. As we discussed, is Schwann cells, your myelin, your axons, all these are being involved. Immunologically, there is an antibody that is sitting and destroying its own myelin. Okay, why that antibody is there? Because of the previous infection. Maybe it is bacterial, or maybe it is your viral infection. And Campylobacter jejuni infection causing diarrhea is most notorious and been associated with GVS. Okay, and few vaccines actually have been associated. Yeah, infectious agents like Epstein-Barr virus, the viral infection, cytomegalovirus, and Mycoplasma pneumoniae, and Campylobacter jejuni, and immunization with the influenza. Now, flu vaccine, when few studies in thousands of millions, 1 in a million incidents, they can flu vac can give GBS. This is uh, just for understanding. Okay, or surgery may trigger antibody production via molecular mimicry. Okay, the same thing. You just, this is all similar to your acute rheumatic stuff. Okay, glomerulonephritis, rheumatics, and this is similar to that GBS. This is something that is renal, that is cardiac, and this is your CNS, the molecular mimicry stuff. Okay, yeah, these are the clinical variants. These are not of much of use clinically, but this is mostly very useful to filter a candidate for NEET exam and PGs. Okay, this will be asked as your entrance bit. Not of much practicalities. Whatever be the condition, we give IV immunoglobulins. But for your interest, it is how many variants? There are so many. Yeah, acute inflammatory demyelinating polyneuropathy, most common, occurring around 70% to 80% in different proportion all over the world. Yeah, and the antibodies that we can expect is GM1 minority. See, not just remember, most common type, you may not have much of antibodies to blame to. Okay, only few GM antibodies may be present. GM1 antibodies may be present. See, this is the AMAN, the next the next common thing. Acute motor axonal neuropathy, GM1 and GD1A antibodies may be present, and acute motor and sensory involvement of both motor and the sensory manifestations. This is not very much from here. It is not much common. Remember, these two mostly constitute your GBS mostly. Yeah, the same antibodies. And Miller-Fisher syndrome, this is your entrance. Yeah, in our entrance we got it. Actually, yeah, Miller-Fisher syndrome, most common, and GQ1B and GT1A. Okay, just remember, which is your memory. And there is another variant. You may not see a reflex, you may not see any weakness of the limbs, but you can present as a pharyngeal cervical brachial variant. There is something called pharyngeal cervical brachial variant, where it is very rare to occur, and these are the antibodies GQ1B, GD1A, GT1A. Okay, polyneuritis cranialis, acute sensory neuropathy. This is absolutely sensory. And GQ1B, GT1A, and acute pan dysautonomia. This is absolutely autonomic system mostly affected. Your blood pressure, heart rate, sweating, pupillary changes, all these things. Okay, not much of no antibody is being attributed till now. Research has been going on, and maybe in few years we may find another entrance bit. Okay, acute ophthalmoparesis. Yeah, the same things actually. Just remember, GQ1B, GT1A is repeating most of the times. Okay, this is how I remember. This is, yeah. Yeah, coming to the investigations, mostly clinical. Child, absolutely normal child with previous infection of 1 week, sorry, 2 weeks to 4 weeks back, in 1 month history of GA or respiratory, coming to with weakness, absolute weakness, no reflex. Yeah, you may think of GBS, who is apparently normal, a well child. And you do lumbar puncture, you see more protein in it, and albumin cytological dissociation is the term given. Usually proteins and cells goes hand in hand. If proteins are increased, cells should increase. But in GBS, because the myelin is being broken down more, there'll be more protein in the CSF, but not much of the cells. Okay, specifying that it is not the infection as such. If there is infection as such, there is increase in cells, but there is no infection. It is an autoimmune pathology where antibodies are eating its own myelin and its own nerves. Okay, and yeah, neurophysiological studies, as we discussed, is the flattening F waves and all the stuff. Okay, and radiological investigations, like you can see the demyelination in MRI. Yeah, post gadolinium enhancement of the peripheral nerve roots and caudal cauda equina is seen on spinal MRI in as many as 95% of children with GBS, and its regional variants. But it is not specific to this disorder. It can happen in any inflammatory infection of the nervous system. Okay, so this is not very specific, but whenever you think of the symptoms are fitting in, you can do a spinal MRI, and you can see that there is demyelination over the nerve roots. And yeah, and yes, we have discussed a table. So you do antibodies, ganglioside and ganglioside antibodies are identifiable in around 50% of the children. Not that everybody has it, only in 50%. Yes, you may find lucky, and you can present a paper. The differential diagnosis, all these constitutes the acute flaccid paralysis spectrum, and acute flaccid paralysis is your poliomyelitis, transverse myelitis, and traumatic neuritis, and one the acute disseminated encephalomyelitis also can present with such manifestations. Okay, yeah, yeah. So coming to the management, how do you manage the case? This is very simple. Once you diagnose it, once you know that you're dealing with this thing, you can think of supportively, just look for any respiratory. The most important thing is your respiratory tract that is getting hit, and respiratory failure is something that we have been expecting. So see through that the child is observed continuously for that, and doesn't drop into, because it is a rapid progression can be present. So it is mostly supportive, and both the two main modalities you want to hit it hard. It is the two modalities, IVIG, that is intravenous immunoglobulins, and plasma exchange. Okay, the two things. And coming to the, and actually, to be frank, this is mostly self-limiting. You give medicine, you don't give, it is going to subside by its own. Not most of the cases, but yes, in some 30% or the 40% of the cases. But we never know what is the case that is going for respiratory failure and other serious manifestations. So we have to intervene and give treatment. That is your IVIG. In case of pediatrics, we do IVIG because it is based on the weight. So kids are expected to be lesser weight, so less dose of IVIG can be given. This again the cost. Each 5 grams is around 20,000. So you may have to shell out a lot of money. So in adults, we do mostly plasmapheresis and plasma exchange, okay, which is a more cheaper alternative than your IVIG, because at 60 or 70 kilos, if you want to do IVIG, it's going to take lakhs. Okay. Yeah, coming to the human immunoglobulins, IV, intravenous immunoglobulins, they help in binding pathogenic antibodies, the antibodies which we have discussed, and down regulation of B cell mediated antibody production. The production itself will be decreased because these immunoglobulins are going to act on B cells, and accelerated antibody catabolism. Whatever been formed will be eaten up by these. This is an immunoglobulins are antibodies to the antibody, and complement inhibition. Whatever the basically the immune thing will be fought back again. Okay, now coming to the plasmapheresis is what they do is they'll filter in the blood bank. They'll be doing it. There'll be a filter. They'll take the patient's blood, and they'll filter the blood and again give back into the patient. So that is plasmapheresis. Okay, reduces levels of circulating antibodies. They'll remove the antibodies and may reduce levels of circulating pro-inflammatory cytokines or cell adhesion molecules. All these things will be filtered out, and again the plasma will be injected into the patient, his own thing. That is your plasmapheresis. Both appear more effective when given within 2 weeks of onset. The timing is important. Once the onset is there, you don't wait for long, uh, because respiratory failure can occur at any time. You be fast and act swift, and you have to treat very fast within 2 weeks. If you're going to do either of this, but do it early. Okay, immunoglobulin is generally preferred for the treatment of childhood GBS because of the cost and yeah, less side effect profile, and a total dose of 2 grams per kg. This is important. Please make a note in notes or in Viva. You please tell this: 2 grams per kg of IV immunoglobulins over 2 to 5 days is generally well tolerated at all ages. And plasma exchange or plasmapheresis is a well tolerated effective treatment of GBS for children weighing more than 10 kilos. And the logic stays. Okay, just imagine 2 grams per kg, where 5 grams is going to cost you 20,000. That's the cheapest. Okay, 20,000. So just imagine if it is some 25 kilo kid come, and if you want to give immunoglobulins, you have to give 50 grams of immunoglobulins, and you're going to shell out 20 lakhs for immunoglobulins alone. Sorry, 2 lakhs for immunoglobulins alone. Yeah. Yeah, coming to the prognosis, yes, children with acute inflammatory demyelinating polyneuropathy, which is most common variant of the GBS, generally recover more quickly than those with AMAN, the motor or other condition. Most common thing will go fast most of the time. God has made it like that. Most common thing will get better quickly. Don't know why. Yeah, most most reach their clinical nadir within 2 weeks. Everything happens in 2 weeks. Recovery begins soon after, and few have significant impairment by 4 months from onset. Okay, only few will go into residual weakness or this thing. Most of them usually do well. Only 5 to 15% will actually have residual weakness of the limbs, and which will take prolonged period of 4 months, 6 months, 1 year, 2 year, 3 years. And there is some another entity called chronic inflammatory demyelinating polyneuropathy, where they can have repeated GBS, not even one episode of GBS. They maybe have a few episodes of GBS in the lifetime. Okay, every 2-3 years they may have again the recurrence of GBS. Yeah, coming to this end of GBS, hope you understood a bit actually. Now coming to another topic. Yeah, I know this is exhaustive, but yeah, this is the end of it, right? So we'll have a bang for the end. Okay. Yeah, coming to another muscular skeletal disorder, that is Duchenne muscular dystrophies. This is muscular. The previous one is neurologic. Now this is a muscular disorder. Yeah, this is also a very simple thing to hear and all. It is very difficult. Just once you listen to it or read, it is very easy. Duchenne muscular dystrophy is an X-linked recessive disorder caused by mutations of the gene XP21, leading to the deficient or defective synthesis of dystrophin protein. Okay, remember, just dystrophin protein. There is a disorder, deficiency or defect of the dystrophin protein. Okay. Duchenne muscular dystrophy is the most severe manifestation of the group of conditions related to the dysfunctional muscle protein dystrophin. This is the most distressing. There are a lot of manifestations. The mild variants are your Becker's muscular dystrophy. This is 1+1 offer. Like Duchenne's and Becker's, both are almost the same dysfunctions, but Duchenne is most serious and Becker's is less serious. So if you read that, you can write all the less manifestations in Becker's. The same goes well actually. Okay, and cardiomyopathies are milder phenotypes. Only cardiomyopathy may be present, and asymptomatic elevation of muscle enzymes. Only muscle enzymes will be elevated, but there won't be any weakness of the muscle. And symptomatic female carriers can have, and muscle cramps with myoglobinuria is also a manifestation. It may not present very seriously. Okay, yeah. Now, one sad thing is Duchenne muscular dystrophy, because the muscle protein is a defect. There's no way that it can be cured, because genetically X-linked one, it has come from the genes. There is no gene at all. There is a very defective protein, muscle protein, so nothing can be done. That is the sad part of it. But life can be made more comfortable by physiotherapy, surgery, and a positive support environment. See, all these things are just a palliative management, but the fate is already fixed, and most of the patients do and their end meet their end by around 15 to 20 years, based on how supportively they are getting the treatment, and nothing more than 25 actually. Yeah, Duchenne muscular dystrophy is the most common form of muscular dystrophy with the incidence of 1 in 5,000 live boys. Okay, why boys is because it is X-linked. So females X-linked recessive. Okay, females are only the carriers; they just do carry with mild variation, which we are going to discuss later. But male are going to be hit by DMD. Okay, and spontaneous mutations are responsible for about one-third of the affected boys. Not just X-linked, there is a spontaneous mutation also. It is all, mm, yeah, time. Okay, coming to the etiopathogenesis, as we already discussed, it is an X chromosome. These numbers, if you can remember XP21.3 to XP21.2. Okay, it is one of the largest gene in the humans with 79 exons. Why this is important? Because there is a novel therapy for Duchenne's muscular dystrophy with axons. Okay, 14 kb transcript and constitutes around 1% of entire X chromosome. And dystrophin protein is localized on the muscle fiber. What is dystrophin? It is a protein. It is in the muscle fiber plasma membrane towards the cytoplasmic end in the on the inner side. Okay, this dystrophin in association with other proteins like dystroglycan, sarcoglycan, and syntrophin. All these proteins, they will form a protein complex that are helpful in the stabilization of the sarcolemma membrane. The muscle membrane is stabilized because of all these proteins having working in one complex. Okay, during the contraction and relaxation, the stress and strain, the shear forces have been maintained. The cell membrane is integrity is maintained. Once this dystrophin is gone, this complex, the protein complex, the syntrophin, all these things, the protein complex has been damaged. It is defective. So during the contractions and relaxations, there is tearing and fragmentation of the membrane, the cell membrane, muscle cell membrane, that is the plasma membrane. So what happens is when there is a tearing, there is a massive influx of calcium taking into the cells. You must be knowing in pathology, calcium is supposed to stay outside and in proper proportion. If it is more in intracellular and if it is sitting inside, the proteolytic enzymes like calpains and other enzymes, they get activated and will be apoptosis, necrosis, and fiber dies. Okay, this is the sad story of what happens in DMDs. Okay. Yeah, now my clinical presentation, how the child present actually. This is a five-stage method. There is a progressive weakness that happens over time. This is genetic, so congenital. From birth, it will be there. And in 5 stages, it is going to end. Okay. The first one is pre-symptomatic phase. As the name suggests, pre-symptomatic, the child is okay. From birth to 2 years. Early ambulatory phase, once he starts walking, he will find something is wrong. That is 2 to 6 years. And late ambulatory phase, once he is already walking with the defects and he finds that there is a gross abnormality, that is between 6 to 11 years of age. And early non-ambulatory, once the disease is progressing, he'll start unable to walk, bedridden, and all the stuff, that is 10 to 15 years. And late non-ambulatory, that is the end of the story, 15 years. Okay, the main points have been highlighted at different stages. Pre-symptomatic phase, that is birth to 2 years, they may be absolutely normal. They may be absolutely normal at the time of birth because not much of movement is expected in the fetal life, and this thing, it is a closed environment, not much more space to roam around. So once he is born, also he is not ambulatory, so he's okay. But there will be delayed motor milestones like standing and walking in the first initial 2 years of life. Maybe the parents or the treating physician, private physician may not identify it to be a muscle disorder. And then slowly after 2 years of age, there will be frequent falls while walking and calf enlargement. You can see that the calf muscle is getting enlarged. Difficulty in arising from the supine position and squatting positions, that is your classic Grover signs, can be present in this thing when the child is starting to walk 2 to 6 years. Okay, then late ambulatory phase, once he's moving around, he's having delayed milestone and he has the frequently falling child. Now complaints of progressive muscle weakness, and there is inability to raise from the floor, and slowly you can observe that the tendo Achilles and tensor fasciolata of the hamstrings are getting contracted. uh, the limbs are not getting more mobilized as previously, and loss of ambulation and the wheelchair will be by 11 to 13 years. Ambulation will stop because there will be contractures, there will be progressive muscle weakness. So then once the weakness has been well established, atrophy starts rapidly and leading to limitation of movements, and contractures accelerates more furthermore, which are initially the lower limbs and now gets to the upper limbs also. Why lower limbs? It is nothing but they are more walking and more stress, more contraction and relaxation have been from the lower limbs than the upper limbs. Okay. Yeah, pulmonary function tests decline gradually with forced vital capacities and total lung capacities. Your respiratory muscles also gets involved because they are also having muscle cells and muscle fibers. Okay, and then the last stage, late non-ambulatory phase, where severe upper limb weakness and lower limb contractures, respiratory weakness, declining the coughing ability, kyphoscoliosis, cardiomyopathy. You name the muscle, it gets affected. Okay, wherever the thing is there. Okay, most patients die by late teens, as we discussed, more than 15 years, and most frequently by respiratory failure. Okay, and cardiac failure also can be there. They're not just the skeletal muscle, there are few more organs that have been hit, that are the heart, which is also a muscle that will be hit, and the brain. Even though there is no muscle, brain also gets hit, and smooth muscles. That makes them logic. What happens in heart is there will be cardiomyopathy, rhythm abnormality, and it because of cardiomyopathy they may go into failure. Okay, this may be present in 90% of the cases. Okay, heart gets hit hard. Okay, then the brain. Okay, in early life, development coefficient and the developing skills with the motor milestones, the mental faculty is also being affected. Okay, cognitive ability, the learning ability is gone, the developmental standards are less. Okay, intellectual disability can also be there, it can be that detrimental. But apparently the child looks normal because other than the muscles and weakness, the rest of the faculties are good. Only sometimes the brain gets affected. Okay, then again the smooth muscle, being a muscle in GI, it will result in hypomotility, delayed gastric emptying, gastroparesis, and pseudo obstruction. The just muscle don't contract. This is logical, right? Your legs are not getting moved, so your GA also. Okay, because he's not moving, not going around, there may be osteoporosis, your bone gets affected, and frequent fractures and scoliosis. You can't maintain your posture, erect posture, you develop scoliosis. Yeah, and this is something very important. In DMD, they're prone for malignant hyperthermia. If you are giving anesthesia, don't do halothane and succinylcholine. Okay, these are contraindicated for DMD patients because already the muscle has been very damaged more, so it can get further damaged by these. General anesthesia can be very fatal in case of DMD patients if you are doing this by malignant hyperthermia, halothane and succinylcholine. Female carriers of DMD gene are usually asymptomatic or show mild symptoms, can have elevated, yeah, not only male get affected because of X-linked recessive, but female can also have manifestation, but very mild symptoms. They can be asymptomatic, they can be absolutely normal, or mild symptoms. You do the related CPK levels. See, creatine phosphokinase, it is your muscle enzyme. Okay, so you do the levels, they will be elevated occasionally, and there will be mild calf hypertrophy in case of female also. Okay, a recent study has reported about 8 to 22% of DMD carriers can have muscle cramps, muscle weakness, and cardiomyopathy can also be there in a female. Okay, yeah, on examination, how you are going to, what are the things? Examination findings depend on age, at what age you are seeing, because at birth the child is normal, and over the time once the child is gaining years, the manifestations are more evident. Okay, and selective muscle atrophy and hypertrophy are hallmark. your calf muscle hypertrophy is the hallmark. The affected muscles are largely due to the deposition of fats, not that the muscle is getting hypertrophied. It is the deposition of fat in the muscle, okay, that causes the look, the gut, okay. And bilateral calf hypertrophy with a firm and rubbery feeling by 3 to 4 years of age is the hallmark of DMD. The rubbery feel of the calf, hypertrophied calf muscle is the hallmark. Okay, other muscles, not the chest, the calf, just other muscles, the gluteal, quadriceps, deltoid, brachioradialis, infraspinatus, supraspinatus, masseter, lung muscles, sorry, tongue muscles have hypertrophied as well. Okay, and reflexes are diminished, and biceps and triceps and knees are not elicitable. This is also areflexia because the muscle has been affected. See, whenever there is no reflex, either the nerve is got hit or the muscle or the muscle junction. Okay, all this constitutes your flaccidity. Okay, your poliomyelitis, GB syndrome, all these are nerve things. This muscular dystrophy is all your muscle things. If your NM junction, the nerve muscle junction is your myasthenia gravis. Okay, these conditions will result in diminished reflexes. Okay, yeah, contractures of tendo Achilles, because the muscle gets contracted and they cannot relax properly because the membrane is already been torn off. So there will be constant contraction resulting in contractures of tendo Achilles. Iliotibial bands and hip flexors by 10 years of age, he is unable to move, and yeah, all this. You do muscle enzymes, that is your creatine phosphokinase, they will be elevated in DMD and also in Becker's. As we discussed, Becker's and the DMD both are the same thing mostly. And AST, ALT also being intracellular enzymes, they will be elevated, and blood aldolase, lactic dehydrogenase also be elevated, and they are not specific. They can be in any other disease also, but this gives. And 50% of the female carriers, CPK enzymes may be elevated. Okay. And coming to the diagnosis, you make a muscle biopsy or muscle. You see regeneration, degeneration, and opaque hypertrophy, the fat getting accumulated. All these things you can see this in the microscope, light microscope. Okay. And dystrophin immunostaining shows marked reduction or absent staining of sarcolemma with anti-dystrophin antibodies. Okay. In 80%, but if the facility is there, you do dystrophin immunostaining. Otherwise, the symptomatic and asymptomatic carriers with elevated CPK levels may exhibit a characteristic mosaic pattern or dystrophin immunostaining. This is just even in symptomatic or any asymptomatic also. If the CPK is elevated, you do a muscle biopsy and you can see this mosaic pattern. This is again entrance thing. Yeah, gene mutation, you know that XP21.2 and XP21.3. So you do genetic study and it gives your this thing. You can see that there is a defect in the deletion is the most common thing, and duplication can also be seen. Okay, if mutation is not identified, dystrophin gene sequencing and mutation scan is required. Differential diagnosis, you look for other disorders like spinal muscular atrophy type 3, Pompey's disease where the heart is also involved. So Pompey's, muscle and heart both are involved in Pompey's. This is a glycogen storage disorders. And yeah, congenital muscular dystrophies can also be there where the CPK enzymes are not much elevated. And limb-girdle muscular dystrophy, which is a autosomal dominant or autosomal recessive, not an X-linked. So you can see this in female also. Okay, all this constitutes your differential diagnosis. I'm making it fast because we're running short of time. Yeah, management. Yeah, as we know, as we discussed, there's nothing can be done. And physiology, so the physiotherapy is the mainstay. And pharmacotherapy, because sometimes you can see antibodies for dystrophin protein. So you do steroids, prednisolone in dose of 0.75 mg per kg daily, or deflacord 0.9 mg per kg per day. So supplementing this, you're going to just make the functional status better and prevent the contractures. That's all. It is not going to change the disease all such. Anyway, it has to. It may add only few quality years to the patient. Nothing more than that. Eventually, the patient goes bedridden, respiratory failure, and succumb to the disease. Okay, this is just only this thing. Steroid therapy reduces the risk of scoliosis and pulmonary functions. Okay, genetic counseling, X-linked. So tell the mom that yeah, there is something wrong with your genes. So if the mom is getting to be pregnant, there's 50% chance that you can transmit the either the gene or the uh, defect. Okay, males are affected, females will be carriers. Okay, this concludes both topics, GB syndrome and Duchenne muscular dystrophy. Okay, and yes, if there are any doubts, we'll go with the doubts first. Otherwise, we can conclude the class. Any doubts, guys?
No, sir.
No, Pavan. Yeah, thank you, thank you, thank you all. Thank you for your patient hearing. And yeah, we'll meet you soon. They told that from tomorrow, some few days, maybe you're expected here in the department physically, not in virtually. I don't know whether you got the notice or not. Yeah, this is the last class for theory in pediatrics, I think. So all the best to you guys. Okay, all the best. Thank you once again.
Thank you, sir.